I'm Bobby Anand. I'm a knee surgeon based in Surrey and London area. And this talk is something I've been working on around six, 7 years. We did it in conjunction with Xiros, looking at minimally invasive technique for MCL reconstruction. Disclosures, I've been involved with development and teaching work with Xiros. However, as Kate Moss would say, they don't really pay me enough to get out of bed for that. So this is really a labour of love more than anything else. Synthetics in the knee is nothing new. It's been around since the 1960s, and over time there's been significant material design improvements. The literature is really focused on ACL with very little data on extra-articular work. So the aim of this study was I suppose, a retrospective review of my cases was to look at the outcome of minimally invasive surgery when we're reconstructing the MCL using a sort of an anatomical based approach with the Infinity Lock 5 tape, which is a flat suture polyethylene tape. So this was a retrospective review looking at 34 consecutive adult patients who underwent MCL surgery with a minimum of 2-year follow-up, and this is over about a 5-year period. So we started this work around seven years ago or so. So we're recording PROMS data looking at IKDC, Marks Activity Score, and KOOS. This was either collected in clinic by the registrars or a telephone follow-up. The MCL, I'm not going to bore you with because we're limited with time, but it's often regarded as the neglected ligament of the knee. The anatomy remains debated, and there's been lots of interesting papers on it recently. But if you really simplify it, there are 3 key parts to the MCL. You've got the superficial MCL, which I think we all recognize as the most important bit. You've got the deep MCL, which is a capsular type attachment, and then you've got the posterior oblique ligament. And Leprad's done some really amazing papers on this, and the diagrams and illustrations are fantastic. And he really, points out the anatomy nicely. I'm not going to go into detail on this, but it's quite interesting. The POL and the deep MCL, there's a significant overlap in terms of the anatomy described. So this is a diagram my group has done looking at the anatomy, and it's a very technical diagram where we looked at various landmarks that have been described in the literature, and we've quoted all of them there, and we've come up with the points where there's sort of hybrid points in all of those aspects. And really the summary is the primary valgus stabilizer of the knee is the proximal division of the superficial MCL. Primary external rotation stabilizer is the distal division of the superficial MCL at 30 degrees. And internal rotation stabilizer is the POL with the distal division of the superficial MCL. So this is a sort of I'm not going to go through the technique, but if anyone wants, you can get it from Xiros. So this is a summary of the technique. You get 3 incisions. The first is about a 1 to 2 centimeter incision. I started off doing really small incisions. I've actually gone a bit bigger. I do about a 2 centimeter incision over the medial epicondyle. And then you find your point there, fix the tape, and then have 2 strands coming off that, one for the superficial MCL and one for the POL. And the first diagram on the left, I haven't got a pointer on this, sort of scribbled out, demonstrates that. And so that's what it looks like afterwards. And when I first started out, I was using Leprad's drawing and just scribbling over it with a marker pen to demonstrate the landmarks that we were looking at. We've got a bit cleverer now. We've done with the guys we're working with, we've done a proper diagram of the landmarks that we're looking at. So for the femoral attachment, you're almost making a triangle between the medial epicondyle adductor tubercle and that point we're using. The superficial MCL is about, for the average sized person, about 6 centimeters down from the joint line, and the POL is 1 centimeter from the joint line, anterior and posterior. So it's that posterior crest. So real quick summary of the results. 2 patients were excluded who were adults. 1 was lost to follow-up. 1, I did an MCL reconstruction on a uni patient, which was very experimental, and she's done fantastically. She had a Oxford uni fall, completely ruptured her MCL, So we're discussing revision, and I thought, I'll try this. And she's still going. In fact, I'm doing a uni on her other knee in a couple of months, and she's still going strong at 5 years. The MCL did really well with that. So with the patients that are included, we've got an average follow-up of 29 months. Clinically, there's been no significant difference in opening of the joint on either knee. We said 30 out of the 32 patients recovered well, and I suppose from that, what I'm saying is recovered within 6 months to what we were aiming for. And so we had pretty good results for that. One of those 30 did require a further operation, so 3 out of 32 needed a reoperation. But even one of those who had the reoperation got back to rugby at 6 months. So the 3 reoperations were 2 for removal of femoral anchor and 1 for removal of tape with the anchor. There were no MUAs needed. So this was the case mix. It was a mixture of multi-lig cases and isolated MCL, and a mixture of acute and chronic. So the majority were chronics, but there were some acute ones in there as well. These are the scores. So generally, we found a significant improvement in all scores, KOOS, IKDC, and Mark's activity score. So the results were pretty good. So really, this comes down to the evolution of my journey with MCL. I was trained by some legends of orthopedics, and we were doing open repairs and then using synthetics or allografts for repairs, and these are sort of incisions we used to make, and that's how I was trained. And then and then the internal brace came along, and I was quite keen on the internal brace, and I used that a little bit, but I definitely had a few failures with that. And the thing that precipitated my change was really, I had a basketball player. He was a junior doctor in A&E in the hospital I worked, but it was on a scholarship to the US for basketball. He had a PCL and MCL, so I reconstructed that, and he was brilliant, apart from the MCL failed on the internal brace. And I just always felt that wasn't good enough for these really severe MCLs, and that's when I started looking deeper into it. And really, this has been my approach to MCL surgery: isolated femoral, which are the majority, grade 1s and 2s you leave alone. Grade 3s, most of the time you still leave alone. There is a group that you start thinking about surgery, and particularly in football and rugby, particularly if there's a deep MCL, POL involvement. Isolated tibial-sided, as most people would probably operate on all of those. And in the multi-ligament scenario, often I'll operate on those. So really, this is a simple technique. I'm a simpleton. I can't deal with too much complexity. It's a single fixation on the femur, double fixation on the tibia, and it's been doing pretty well. And so these are the sort of positions where we're fixing it. This is a case example, recent one. He's not actually included in the study, and he's been amazing. So he's a 24-year-old rugby player, plays for a really good club. He did rehab, didn't do well. He was fine post rehab. He ran the London Marathon before having the MCL done. He ran it in 3 hours something, but not been able to return to rugby. The knee has been giving way on him. I mean, even during his run, he was struggling, but he's just a machine and got through it. So, but that was the level of instability he had. And this is 18 days post-surgery. So it's an operation that in my hands has worked really well. We do not brace any of them now, no matter how severe the instability is. This works, and it's pretty solid from day one. So that's him. And I've had another one from that club recently who's had surgery, and he's also, touch wood, doing really well. So my observations when I started doing this in 2028 was the pain was significantly less than open MCL surgery. I was finding that generally there was a quicker recovery. I was bracing some of the really severe ones, but around that time I stopped bracing completely. And we've had a really predictable return to sport. So it's been okay. These are sort of just some close-up pictures of the incision sizes and how we do it. The key is really to get those landmarks accurate and pass the tape in the right layer between layer 2 and layer 3. So really in 2023, I had a sort of another brief look at the data, and we had no further failures, no failures and no reoperations. And this is a recent diagram where we've looked at the landmarks in a bit more detail. Hopefully we'll be publishing on this soon. Going into detail of, I'm never interested in the good ones, it's the bad ones you want to look at. So looking at the problems we had, most of the problems were in the earlier cases. I had 5 cases that had some pain from the tapes, 2 resolved without needing to do anything. There were 3 that remained and were having problems. One was this elite player. He was a really good rugby player. He had pain over the femoral attachment. I did a steroid injection in that area. It helped, but it was just bothering him too much. So I just removed the anchor and released it, and he got back playing really quickly after that. I had another one who was a footballer who was slow to recover. Again, it was the femoral sided anchor that was a problem. Removed that, and he settled quickly after that in a couple of months and got back. The only problem patient really was a police officer, and she had a tibial sided pull off, and she just had constant diffuse pain over the MCL. And this is was a little bit interesting because I did get to scan. This is the only patient I've got to rescan. And so if I can, sorry, that's the post-stop scan. They should be playing the other way around. And you can see there's a bit of a reaction around the tape. So the MCL is healed beautifully. If you see the first one in a second, the MCL is healed really nicely. There was a bit of reaction around the tape, and I was worried, is this a low-grade infection or is there something going on there? Sorry, this is the first initial injury scan where you see the tibial side has completely come off. She was really opening up significantly. And I didn't reattach that. I didn't open up and reattach the tibia. I just literally did that repair that I've described. So I took her tape out. She was still a little bit slow for a while, but the tape gave me an opportunity to look at the histology as well when we took it out. So this is the first one I had some histology on. And this is quite interesting because it really did show that that tape had, the tissue had grown through that tape and it had embedded really nicely into it. And I found that with the other 2, you can barely see the tape most of the time. There was no infection in the end, so not quite sure why that reaction was. But even after that, she still had pain for 3 months, and we actually did a bit of shockwave therapy, and she got back, and she's done quite well. But she was the only really slow patient I've had. So she is a consultant now. She's a general surgical consultant. So she was an ACL, MCL I did. So I have done it on colleagues. So that shows how much trust I have in it. She's done fantastically. 90%, I think, plus now recover straightforward without any problems. Up to 10%, i.e. those 3 cases have had some problems. And I don't know, I haven't got enough data on the complex, the problem ones to understand the cause. My suspicion is it's irritation from the tape around where the anchor is. So I definitely bury the anchor a little bit more. I don't think it's over constraint. I think you've got to put them in quite tight. I've not had an issue with stiffness. I think if you leave them a bit loose, you're more prone to getting irritation. And obviously you always question your position of fixation. Was that the cause of those 3 having some issues? So really in conclusion, in my hands, this has been a real significant improvement in my MCL practice over the last 6 years compared to what I was doing before. I'm getting really good results. It's predictable, and I think it's a relatively safe technique. Any questions?